Good afternoon, everyone, and welcome to our 8th and final presentation in our 2019 Reducing Preventable Hospital Readmission webinar series. This series has been focused on the targeted strategies for improving care transitions that we've identified in Virginia hospitals. My name is Joyce Dayvault, and I'm the Director of Performance Improvement in the VHHA Center for Healthcare Excellence, and I am your moderator for today's presentation. Before we get started, there are a few little housekeeping items that I'd like to cover with you. All right, as you can see on the screen, our webinar is being recorded. The presentation is also located in the handout section of your webinar sidebar. We ask that you use the telephone option, and if you have speakers on your computer, you may need to mute them. All participants are muted in this presentation, and we ask that at the end when we're asking you have questions to ask, that you type them in the question box to the sidebar. At the end of the presentation and the closing, there will be a feedback survey that will launch when you check out of the webinar, and we very much appreciate your input and letting us know the benefit of this series and this presentation today. Of course, the purpose of our presentation series has been that we wanted to share successful strategies in use by our Virginia hospitals and health systems that have shown to improve care transitions and reduce hospital readmissions. We also wanted to work on increasing transparency and facilitating networking amongst our hospitals, our health systems, and our community partners. Here again is the series of hospitals that were willing to take the time to share some of their interventions and their programs that they've put in place to reduce readmissions. Today being our last one, I want to present the team from the University of Virginia Health System. With us today is Dr. Paul Helgerson. He's a section head for the hospital medicine at UVA and associate professor of medicine there as well. He serves as the medical director of UVA's interactive home monitoring program and is also the service line lead for the general medicine medical subspecialty service line at UVA. Also attending today, presenting today is Novella Thompson. She is the manager of the UVA Health Population Health Department. She has used her clinical counseling and advanced lean management background to predominantly work in occupational and preventive medicine for more than 15 years. She developed the advocacy model currently used in multiple medical center programs and leads a 43-person team there at UVA committed to the overall health and well-being of several populations. John Michael is also the director of data science and at UVA, and he has been with over 25 years of experience in data science. He leads a team of data scientists working on the health system's most challenging problems, that certainly including readmission prediction. I'd like now to welcome Paul, Novella, and John, and Dr. Helgerson, the floor is yours now.
Thank you, and let's go on to the next. 2 slides, actually, I think, beyond the introduction. There you go. One more. Thank you. So, again, we appreciate the invitation and the opportunity to share the work that we've been doing here over the last couple of years in readmissions reduction. I felt it appropriate to lead off with just a few bits of information about who we are. Most of the participants will know that we're a relatively large academic health system that includes about 600 inpatient beds that run the full spectrum of specialties. But I think it's also right to contextualize that we have a comparatively small, for the size of hospital, outpatient primary care network around us. The payer relationship is largely fee-for-service with less of a population health element. And therefore, the incentives around readmission reduction, I think, need to be thought of as what we can do to both, work within that relatively traditional model, but be thinking about a population without a lot of financial resource behind what it takes to get us there as it relates to that inpatient population. I think the other barrier that we have is that we have a very big catchment area that, particularly to the west, we skew, hours away, and that many patients that we're discharging aren't necessarily within our primary care network, but are more related to the many subspecialties that we have here. So on to that next slide.
Oh, hang on. Sorry, hang on. Sorry. There we go. Sorry.
The work that we're presenting today was done within the general medicine, or what we call medical subspecialties service line. That is now up to about 6,000 discharges a year. About 3/4 of those patients go home or to home with home health support. The other 25% to SNF or other inpatient settings. And at the time of this work, the baseline readmission rate was in the range of 16 to 17%, which I think it's appropriate to benchmark as being comparatively unfavorable to the baseline rate in many of these other VHHA hospitals that we're speaking with today, and some of the other large state hospitals. We felt like we had ground to gain. Next slide. What we'll be talking about today is what we've called the Interactive Home Monitoring Program. Our appraisal of the literature and the state of the art at the inception of this work was that it seems that in an internal medicine world that up to about 20% of readmissions may be avoidable based upon expert review, and that the evidence would seem to indicate that it's multifaceted interventions across several modalities that seem to work best. There was some serendipity involved in the program that we designed, which is that in our initial efforts in the population-based health realm, that we had started an employee-focused intervention that we called Be Well, that related to advocates of various backgrounds, trained in a model that allowed them to basically help folks navigate their own care and stay healthier. But that was not in a population of patients that was on the cusp of inpatient admission. So the question was, could we leverage some of those resources and some of the bandwidth in that program and the training and expertise in that program toward a somewhat different cohort, which is a relatively medically ill group of patients that's just left the hospital. That program was, by design already supported by RN, nurse practitioner, social work, pharmacy. And the adaptive work to come, if you go on the next slide,
okay,
is what I'll invite Novella, who is really the expert that has run that program for this section, introduce to you guys in terms of how that works, and then what we may needed to have done to adapt it over to this inpatient population. So Novella.
Okay, great. Thanks, Paul. So Be Well, as Paul's mentioned, was developed. We started developing it in mid to late 2015 and launched in 2016 to better assist our employees and their spouses enrolled in the Aetna Health Plan, which is our personal health plan, to take better care of themselves, address preventative health care issues, have a PCP, meet with that PCP annually. And in developing that, we went through the processes of figuring out logistics for call volumes and documentation, how to support these individuals to remove barriers, and how to make sure that we're addressing the needs around like PHQ with suicidal ideation, depression, anxiety, as well addressing SDOH issues and having resources that combat or break down those barriers to getting the care that people need. The model I built was, it's an evidence-based model that includes many areas from the counseling psychology background as well as performance management. And so around early to mid 2017, I was asked if the advocacy program could potentially help us assist a population of patients who have high complexity diagnoses and high complexity SDOH needs. Next slide. And that's where the IHM program really began to come to life, and so we developed a risk model as we did with Be Well. It is different, and John Michael will talk more about that in just a bit, but it does direct our level of intervention, our call volume, and our outreach, our touches, so to speak. And in that risk level, which is the level of intervention, the advocates then are reaching out to these folks to based on their risk level, on a different level for each risk level, to provide the needs and resources that have ultimately landed them back in the ER and or readmitted, and addressed care beyond the hospital once the patients have been discharged. And so it's been sort of an excavation of each person to figure out what their needs are. Therefore, it's very individualized, and then supported with a clinical escalation ladder, and supported by a nurse practitioner, and other providers that have helped us overcome barriers that patients have experienced. In that, we've also provided a physiological monitoring, which is it's iPad-based for medium and high risk patients and low risk patients who don't have a PCP, because again, that's really important, making sure that care is married beyond post-discharge. While they're inpatient, we do have a meds to beds program that's helping with pharmacy, and then a pharmacy medication reconciliation post-discharge. We do try to manage that within 48 hours post-discharge. We do have a pharmacy team dedicated to managing those calls. And then to provide resources, again, transportation we found was a huge barrier to getting patients to their primary care and their specialty care appointments, appointment management, making sure that the appointments are managed in a time frame that actually suits their schedules. So with hope, we can even maybe potentially decrease the no-show rates. And then ultimately, we know that behavioral health care is vastly important. We knew that with Be Well and integrated that with Be Well, and then carried that into the IHM program. The iPad, next slide. The iPad that the patients are given is delivered while they're inpatient, and it allows us to keep an eye on vitals. It provides us with vital status on scales or on weight, using a pulse oximeter, thermometer, blood pressure cuff, and so on. And the physicians can personalize those needs as well. If it's a cardiology patient, then a provider can specify scales and determine the needs based on what he or she has seen and what they know needs to be provided post-discharge. We do use Epic, and we use an order to trigger the monitoring intervention. The iPad is delivered while the patient's inpatient, as I shared, by a team, and we generally have a caregiver there too, so that the patient and the caregiver are both trained on how to use the equipment, and they're introduced to their advocate, and they're introduced to the clinical escalation ladder, all through education. The other thing that Paul really drove, and it has been extremely helpful, is the disease education specific library of videos on the iPad. And if you have a diabetic patient who leaves with an open wound and has to manage self-care, then there are videos, some interactive, that are linked directly to our hospital video library that helps them also manage care visually and through an auditory means. we do document through Epic and make sure that we connect to the providers post-discharge. We keep the clinical team inpatient in the loop wherever needed, so that we're working together alongside of scheduling, alongside of pharmacy, to make sure that the needs are managed post-discharge, and if care needs to be escalated, that's also managed in a quick and effective way. Next slide, and I'll turn it back over to John, who's going to talk to you about the risk stratification.
Sure, thank you, Novella. So risk stratification is one of the elements of data automation that the data science team has put together for this program. And and actually that's probably the most interesting part, but there are some blocking and tackling pieces that have helped, that data automation has helped this program scale. And so, one of the things that we've developed is an algorithm that automatically detects when a potentially eligible patient has been admitted to the hospital. And that list is sent daily to Novella's team so they can monitor those patients during their inpatient stay. We include information like all the pertinent information, like where they are in the hospital, their risk level, all their demographic information. So the patient advocates are able to monitor those patients over time during their stay. And risk stratification or the risk level is one of the elements of that monitoring that helps them decide, okay, we're going to put this person in this part of the intervention and help with the decision support for the level of intervention. Now, to speak specifically about ARIA-12, it's a artificial intelligence machine learning algorithm that we developed internally using our patient database, and it includes variables from the patient's past years of utilization. And then what we're doing is we're predicting for each patient in our hospital's patient panel what the risk of an inpatient stay within the next year is. And that correlates very well with readmission rate. As you can see, our categories for ARIA-12, in very high, the readmission rate there is 30%, high is 15%, and so on. And that helps Novella's team pick the intervention for the specific patient. And so I'll turn it back over to Paul to talk about the results we've seen.
So next slide, please. So what we've done is a 2-year analysis on then about 7,000 plus eligible patients. This was an intention to treat analysis, so meaning you were considered to have gotten the intervention if you were eligible, not sort of if you, regardless of whether or not you dropped out down the line. But to give you a sense of the way this played out, about 77% of patients that were eligible ended up accepting or enrolling, and then 86% of those patients stayed through the 30 days in completion of the program or got readmitted to the hospitals. Reasonably high, but not perfect uptake of the intervention. Next slide. So sorry, this is a bit faint, but you see that dotted line down the middle when our intervention took place, so that we'd oscillated in the previous years between 16 and 17% as a readmission rate. And what you see here, if you go on to the next slide, is in that post-intervention phase, we seem to have gotten about a 14 relative % risk reduction, or something on the order of 2 to 3% in terms of absolute reduction in our readmission rate across the service line. One question that comes up is are we sure that that's due to the intervention when you're talking about a big population like this, or did UVA as a whole, for example, see a reduction in the readmission rate over that time? So if you go on to the next slide, the answer is yes, but that readmission reduction was not of nearly the same magnitude. So everybody else dropped a 5% relative reduction. We were able to get 14 in a higher risk population. So reasonably gratifying results. If you go on then to the next slide, I quickly then wanted to offer some observations on what we felt like we learned here. I think this was across a big population of patients, a relatively large-scale intervention that both leveraged some internal capability that we already had, but very mindfully took on a multifaceted approach because we felt like that was what was most evidence-based, building a lot of new capability to work with this population in each of those facets. A lot of it comes down to the people work. I mean, this first quote is one of my favorites that was from the nurse that works with a lot of these patients, is that really what this involved in a place that, is sort of one big building of a medical center is a lot of community outreach to build relationships with the places that we are referring patients to meet some of those social determinant needs or the other facets that are really going to help them progress their care. Support from all these disciplines, pharmacy, behavioral health, the scheduling unit that we work with is obviously very critical. And we found that it took, is a garden that required constant tending, if you will, to make the whole thing fit together across arms of the system that weren't necessarily as used to working with one another. I also want to thank both Novella and John, not just for being on the call, but for being just two of the absolutely critical figures. My reference to data science here is just that the ability to tailor the intervention to the patients that we think will be most sensitive to it, I think, is really a key ingredient in the success. And the data science help was therefore absolutely critical. So next slide. I think I also wanted to offer a big picture observation or two. One could rightly ask, hold on a second, Paul, is this cost effective? And I think the question is that that's a really hard answer to give. That it depends a little bit on what the strategy is here and what payer relationships exist in the local environment. My guess is in a strict sense that it may not be if we look at, readmissions penalties through, those diagnoses. But if you consider strategically that we're a place that is constantly packed to the gills and in need of beds, that saving those bed days of care in patients where readmission is not value added, being able to bring other patients in that allow us to serve our mission, that it's been of great benefit to us in that regard in terms of those bed days saved. I think another lesson is that, this advocate model does appear to work even for the very sick patients. There was some skepticism entering in that, gosh, if I'm recovering for sepsis, is a phone call from advocate really what I need, or am I just really, really fragile medically? And the answer appears to be that there's at least a subpopulation that advocate model really helps. I would also say that there's been a ton of collateral benefit from the program, which is you just get so much insight into what doesn't work about your system and needs improvement. And I think we all know that there's a never-ending list of opportunity there, but that we've been able to really think through what we need to change about ambulatory access, about the way outpatient referrals work, and about 8 zillion other things that it's going to behoove us to continue to pay attention to and refine as we move forward. So with that, I believe is the last slide. I will pause, and I think we have, as you look at the names of some of the other team members that have been absolutely essential to making this work, I would invite questions from the group that we're happy to take on.
Okay, if any of you have questions, please type them into the question pod, and I will read them to our presenters.
Well, as we wait, John, Novella, any other observations you'd like to offer? Or I would encourage the group to fire away with any question.
Well, I agree with you, Dr. Helgefson, that the nurse's comment about this is a game changer. I think human beings benefit from that human touch. And when you have the science behind it to help with the iPad piece or whatever, I think this is extremely innovative, and I'm sure you'll continue to see very positive results from your patients. I am beginning to get a few pieces in here, folks, and mostly it is about exciting work, and thanks for sharing. Great presentation, thanks for the sharing. I really like the fact that it was a good way to identify system improvement opportunities. So we'll give them a few more minutes.
Well, on that theme, I think one of the things I can't help but remark is just that as much as that there was a fair amount of investment in putting a team this big together, I've really appreciated the adaptability of the platform, and I think that that's one of the things that would carry through as a lesson is that as in so many things improvement, you realize that the first solution might not be perfect, but that if you have the right resources at hand, that you can retool. One of the things, for example, we found in the early going is that the accept rate wasn't as high when we were contacting patients post-discharge. And part of that is a lot of our older patients, for example, just didn't necessarily trust who they were talking to on the other end of the line if there wasn't a warm introduction. We moved a lot of that introduction into the hospital itself and seem to have seen that acceptance rate improve. There's a lot of little details like that it took to really be successful.
Yeah. I may have missed this, but did you coordinate your efforts with any third-party payers?
Well, I would say in general, no. And you mean in terms of other payers that are running their own readmission reduction program or the like?
Yeah. Or the payers of the patients that you were working with, because I know a lot of the third-party payers have case managers that are working from remote as well.
Well, and you're right to point out that one challenge is that sometimes a patient will say, gosh, you're the third person that's called me today to make sure that I'm doing well after my blank, right? Yeah. And so I do think we've had to be mindful about where other readmission reduction resources or continuity resources existed in transition, and to be mindful of what may be some duplication of effort. Novella, I don't know if you have a take on sort of Be Well as a whole in that regard.
Yeah, I mean, you're exactly right. But I tell you, because we are managing the initiation of enrollment prior to the patient leaving the hospital, we immediately, through our enrollment process, learn if there are others that are calling, if there are others that that patients are engaged with, or who are providing coaching or care, and so internally we can see through Epic who the patient's been working with. That's a huge obviously a huge piece for us to guide our efforts, so to speak. But the patient is typically very vocal about who is working with them, what's not working, what is working, what they want. And of course, if they this is an opt-in program. If they want to participate, by all means, we enroll them and move forward. If they don't, we thank them for their time and move forward.
Yeah. Well, I don't have any further questions for us today. I want to thank all three of you for taking time out of your very busy schedules to provide this information to other Virginia hospitals. Kudos for your work, and I hope it continues to grow and be of benefit to many, many more of your patients going forward. This is our last webinar of this series, and I want to wish all of you a safe and blessed holiday season. Please remember, again, that as I close the webinar, there will be a brief survey. We appreciate your answering. And again, I thank John and Paul and Novella for your time and your excellent presentation. This ends our presentation for today.
Thanks, everyone.
Thank you so much.
You.